No, thanks, Rajeev. And before I go over to Rosie, I just didn't know if Amy or Christy, in terms of Rajiv's question about the challenges with financial security or maybe financial insecurity, that's something that you're seeing up. I've seen some reports where when it comes to emergency savings, that's one area where veterans, as opposed to the non-veteran population, are a little bit behind just having those emergency savings. And of course, that's had some challenges in the last several months. So I didn't know if you had anything you wanted to comment about the issue about financial security or insecurity.
I'll just say kind of briefly is that one thing that we found both with Harvey and then with COVID is the number of people who contact us seeking services around financial coaching, home buying, anything like that, how to increase their credit score greatly increases. And so we were fortunate to have, we could provide emergency financial assistance at the start of COVID, and we did that to veterans and their family members. But once that money ran out, now we're having, now we're in a predicament where veterans are still calling saying, I need to pay my rent, I need electricity bill to be paid, and there's not many people in the, or agencies in the city or surrounding areas that have money that we can refer them to get this money. I think the other thing that was really interesting too is this, we got 2 rounds of money to help, but one of them, the latter of the 2, was one that had kind of unrestricted. So rather than only paying bills, we were able to provide the money to the person, to the veteran, and say, use it as you need to, which oftentimes that's not how money is distributed. It's distributed for a particular purpose. And so, so it's nice to be able to give people choices, right, with their money. I think the last thing I want to say is that as the stress has increased, what I've found with the people that, or some of the people that I've seen, is that they go out and they spend more money because they need to prepare or feel like they need to get certain things in order in case things get really bad. And then that digs that hole a little bit deeper, because they were in my case, right, they were already kind of right at the line of I'm spending a little bit more than I should, and then it got to be I'm spending way more than I should be. And it was good to hear Rajeev talk about how what happens with our money, whether it's delaying payments for the mortgage or the cars, because lots of people did that, but didn't think about, like, well, then how am I going to catch up later? These things are going to extend the impact, and I'm not really sure what we can do about that. So those are my thoughts.
No, thanks, Christy. Now I want to go over to Rosie. Rosie, I know that you have a graphic that you wanted to share with everyone that kind of puts the challenges of exposure to burn pits and those underlying conditions in context. And also, I know that your organization has been working on some different tools, not only for veterans and service members, but also for the providers who support them. So you give you the opportunity to talk a little bit about that. So I'll turn it over to you, Rosie.
Sure. I mean, thank you again for having us. So yeah, the graphic I have up right now is really just a snapshot of the issue, or part of the issue. This graphic does not identify those systemic barriers that I mentioned earlier that we've been able.
I don't think we're seeing the graphic yet.
Oh, not yet.
Right. Yeah. I don't know if you have to share your screen.
Yeah, I thought it was, hold on a second. I thought it was this little tab. Is that it right there?
No, we're still not seeing it.
I think
we're the ones struggling with technology today.
My apologies.
No problem at all. No problem at all. But I know you can talk it. I know you. I mean, you know the subject inside out. So please feel free to continue.
And Rosie, this is Sean. Randall and I are going to see what we can do to help you get your screen up if you want to just start into a little bit of the description.
I think we.
So
sure. Yeah.
Randall is navigating that with Rosie at the moment. Maybe we could take a second and answer some of the questions that have come in.
Yeah.
I know, Sam, one came in earlier that I passed along, and I'm sharing them with you in the chat along with if they're coming to individuals. And someone had asked specifically about the numbers that you said in your opening. Are there numbers available on the deaths in nursing homes? I don't know if you have that specific info at hand. If not, we can do a follow-up.
I don't know if any of our other panel members, but we can definitely follow up on that. I know, anecdotally, I think we've all seen there have been different facilities across the U.S. that are focused just on veterans, nursing home facilities, long-term care facilities. And I know anecdotally, we've seen those just really have some really, negative impacts, really get hit hard by this. But that's kind of anecdotally. I'm not quite sure what the numbers look like across the country. I don't know if anyone else does, but that's obviously a challenge. Go ahead, Rajeev.
I don't know that specific question, but I just want to raise the point that, oh, look, there's Rosie's screen. Just quickly, what I think this situation has taught us is how much better our data systems could be. There are, whether it's in terms of COVID infections, whether it's in terms of mortality, whether it's in terms of suicide, or or increases in substance use, or we're all dealing with projections and forecasts, but this is happening in real time. So I'm working with a group of other federal agencies and private partners to think about how can we use this movement, this time, to invest in our public health infrastructure, especially for disease surveillance and monitoring, so that we can get real-time data, so that we can get accurate data that we can make informed policy decisions with, as well as identify groups at high risk. We might think that group A, group B is at high risk of increasing their drinking behaviors or whatnot, but we need data to actually confirm those hypotheses, and we need real-time data, or as real-time as possible. And we're working on that and trying to garner support to increase, and surveillance comes in about, I don't know if Rosie's now online, she can talk about burn pit surveillance as well, but her registry is a perfect example of another area where we need kind of better surveillance capacities.
Okay, and Rosie, we'll go to you. We can see your screen now. We can see the graphic.
Okay, wonderful. And Sam, go ahead and highlight again what your question was, for me right now, just so I can cover the graphic.
Yeah, I just wanted you to kind of hit the highlights there on this graphic to just kind of put in context in terms of the challenges that burn pits bring, as well as I think, a pretty important data point would be some of those health impacts, because I know you and other organizations have done a lot of work in identifying what those underlying conditions are that exposure to burn pits has brought out. So highlighting some of those.
Right. Okay. Thank you. Yeah. So, this graphic really is just a snapshot of, it doesn't really identify, sorry, a lot of those systemic barriers. Let me just get some water. Sorry. But it does highlight the issue. We see here on this graphic that it talks about, the amount of waste that was burned, the materials that were burned, and the active burn pits that are still in operation. It highlights Joint Base Balad, which was one of the biggest bases that, one of the bases that operated one of the largest burn pits, and the amount of toxins that were generated as a result of it. So the health impacts that are identified here are what we've identified through our own registry, right? And really just highlighting what those effects are that are being self-reported. We don't have access to all of this information through the VA Airborne Hazards Open Burn Pit Registry. So it's just really important that we're able to report and have access to these illnesses and deaths resulting from exposure. So you'll see on here that we have identified or sort of highlighted some similarities or comparison to the 9/11 community. And the reason for that is that we actually took the air sampling from the World Trade Center, and we took the air sampling from Camp Anaconda. And I want to say about 10 to 12 of those dioxins were the same dioxins, which are a majority of those are carcinogens. So, you know, we made the decision to partner with those advocates and really bring forward the reality that, you know, the question shouldn't be scientific anymore at this point. The question should be like, how can we fulfill that moral obligation to help these service members and survivors get the justice they need through compensation and through acknowledgement.
No, that's great. I also, could you touch upon, I know you guys just developed a toxic exposure table where it makes linkages between the toxins or the chemicals that are being produced or that were produced in some of these burn pits, and kind of how it's impacting, how does that manifest itself in terms of illnesses or symptoms that could be very useful to providers. So I just wanted you to give a chance to, if you could elaborate that on a little bit more, and then how could people, if there's people here in the audience who are providers who want to access that, so they can maybe use that in terms of how they're treating veterans, where they could find that table.
Sure. Back in 2010, the VA developed an environmental training letter whose sole purpose was to be a guide for VA adjudicators when they were processing these claims in regards to burn pits and other exposures. So in that letter, it's 26 pages, but in that letter, they identify those dioxins, right? And they also identify the possible health effects and organs affected. So what we decided to do was, because we have so many veterans that come to our registry and are really just begging for help. We have widows, survivors that call us and say, you know, my spouse or my daughter, or my son, or mother, father, or whatnot, that their illness or cancer was not acknowledged or connected, and so they have no benefits. You know, they're just pretty much left out in limbo. And so we decided, like, how can we take action now? Because we know VA and DoD are really just leaning more on that they need more research. So we took we being members of our scientific advisory board and their team of experts took the table and broke it down into only 6 pages, if I'm not mistaken, and really just targeted the health effects and organs affected according to that national directory of how those dioxins are classified, if one is a carcinogen, if it's not, but then really just highlighting the fact that individually they have its own impact. But when you have combustion burning of all of those dioxins together, it produces new dioxins. One of those dioxins is Agent Orange. And you'll see it in the letter, which is uploaded in our website. You can find both documents on our website. You can find the original VA environmental training letter, as well as this toxic exposure table that we feel will really not only help the veteran or the survivor, but really, or the caregiver, but also help the clinician to better understand what they're dealing with. But I can also say, Sam, that what's needed really is these clinical guidelines and most importantly, an acknowledgement of association, because until we have that, you know, we're not going to have much to work with here.
No, and I know that that is a fight that is continuing, and there are some legislative efforts that are in some cases tackling that head on. In some cases, maybe they're kind of nipping around the edges a little bit, but no, I completely agree. You know, it's getting past that, I think, will actually maybe open the door to greater access for veterans and their families to the treatment they need to deal with this, as they could potentially be dealing with COVID as well. And also, before I forget, Rosie, you have an event that's coming up here in a couple of days. Do you want to take a chance to kind of give a shout out to that and where people can go if they want to watch that virtual event?
Sure. So what we've done this year, here we are a decade into our advocacy efforts, is we decided to really adopt what the 9/11 World Trade Center advocates had done, and that is develop their own coalition, sort of police unions and first responder unions and public figures, veteran entrepreneurs, companies, just Americans to really join that movement. So we partnered with Grunt Style, which is a veteran-owned company based out of San Antonio, Texas, and decided to, here we are in the middle of a national pandemic, and that doesn't mean that these veterans are not still sick and dying, right? That these caregivers are trying their best to deliver the best kind of support that they can, because it's tough. We live it every day. So we decided, how can we all sort of asked ourselves this question, and if many of you don't know, we have, Jon Stewart, comedian, actor, activist, who asked that question, like, how can we help now during the pandemic so we don't have to wait until everything reopens? And so we decided to put together this military toxic exposure conference that brings those experts together in one room to help really highlight the importance of all those aspects of the issue, like compensation and research and VA policy and healthcare, and then really just bring it home with that call to action from John and John.
And that's going to be this Friday.
Yeah. So if you want to join and watch, you don't have to register. We just sort of threw out that Eventbrite link, but you could just log on to the Grunt Style Facebook page, and it'll be live streamed through that platform at 6 p.m. Central Time on Friday, the 28th of August.
Okay, great. No, thanks for sharing that, Rosie. Now I'm going to go to, we started to get some questions in, and so I'm going to go to some of those questions from the audience. And the first one is to Rajeev. So Rajeev, what are your thoughts on screening for a genetic predisposition for PTSD and innovative objective tools to reduce stigma?
Yeah, so this was answered in the chat. So I don't know all the data on the genetic screening. I know that there's some conditions like Huntington's disease that there's an absolute kind of linkage and genetic screening. I don't know. I haven't heard that they're great, but I'm not as familiar with the literature about kind of these genetic markers for mental health conditions or combinations thereof. I do like the idea of using information, however you might collect them information, to identify high risk strata. So for example, if a patient comes in that Amy or Cristy is seeing, and they have an indicator that this patient, based on some intake form, that this patient may be at elevated risk for suicide, let's say. I think that that's a useful clinical tool that Amy and Cristy can use, and maybe be more proactive in doing a suicide risk assessment, or developing a safety plan, maybe probing into figuring out why did the data indicate this. But for any of these kind of pre-screening or indicators of people who may be at a high risk strata or high risk for a certain outcome or high risk for PTSD, or even in the general population, people who may be at high risk for having a mental health condition, I think we need to think at the same time about what do we do with that information. So are we helping the person, or do we use that information in a punitive way and somehow harm them? In the military, for example, do we do a screening, figure out somebody is at high risk for something, not absolute risk, but they may have a greater probability than the person next to them of whatever the outcome might be. Let's just say suicide, because people are thinking about it. So they have a greater predisposition to suicide, or a greater probability of suicide. It may still be low, absolutely. It still be maybe under 5%, but maybe theirs is 3% and someone else is 0.5%. Well, do we then say, well, no, you're no longer eligible based on this data. You're no longer eligible for this career, this opportunity, because the data suggests that you're at increased risk for suicide. I think, and I say that because I actually worry that is somehow is how the data could be used in some cases. So all of these screening tests we really have to think about false positives, how many people will screen positive but are not at risk of the outcome, as well as what do we do with the information and how can we use it to help people and not punish them or not create systems that are punitive towards them.
No, thanks, Rajeev. And question for Rosie. Reference our experiences in the first Gulf War with the oil fires and the oil wells. Was there anything learned from that experience that we've been able to apply to how we are thinking about exposure to burn pits now?
I mean, yeah, I feel like we really failed the Gulf War veterans with how things were overlooked and things were handled in regards to compensation. They're still, the organization that's run by Anthony Hardy and Paul Sullivan over at Veterans for Common Sense. They've been working for over 20 years on research and all kinds of advocacy efforts on their part. But I feel like we really need to hold DoD and VA accountable to really deliver that the services that are needed. We really need to pay attention and make sure that the right people have access to those air samplings and any data that was out there that was conducted either through an independent source or through our own government. So, we see so many of the Gulf War veterans really coming to us and asking, why have we been left out? Why are we forgotten? And we don't want to repeat history. And it feels like this is all a repeat of Agent Orange. So yeah, I think we just need to do a better job in making sure that that it's all inclusive of all of these war campaigns that have faced that same system that we're facing today.
Yeah, and that's something you brought this up a minute ago, and I don't want to lose this. Is that we've dealt with toxic exposures before when we dealt with Agent Orange, and I still think we tend to, our Vietnam veterans, we still struggle with making sure they're getting the support they need. So I want to make sure that they're also part of this conversation, the underlying conditions they have from exposure to Agent Orange. And obviously it's a much older population and they're having to deal with COVID-19. I mean, we've just now gotten to the point where we're recognizing military caregivers for Vietnam veterans. And here we are in 2020, and we're just now getting to the point that we're providing ways that they can be compensated through the VA. In fact, I still think it's not going to be, it may not be official till October. So we still haven't necessarily gotten that for our Vietnam veterans. So always making sure we always keep a spotlight on them and make sure they get the support that they need. I wanted to go back over. Oh, I'm sorry. Go ahead, Amy, please.
Yeah, I have kind of to tie in that, a lot of times when we talk about COVID infections, we talk about the people who have asymptomatic or the people who died, but there's this whole group of a cohort of people who are going to be called the long haulers. They have the late consequences and the long-term illnesses. And some of those illnesses are really vague sounding in the early, I mean, we're still really early about understanding what the long-term impact of COVID infection will be, but there's things like fatigue, trouble breathing, trouble concentrating, headaches. A lot of those things are really easy for people to say, oh, that's all in your head, which is not what people want to hear. I'm sure that's some of those same symptoms are coming from the burn pit experiences, that there's fatigue and there's breathing problems and there's concentration problems and headaches. And there's a real reason why folks are facing those things, and being told it's all in your head. Oh, yeah. They don't want to, yeah, that dismisses the whole thing. And it's going to be hard to tease out, like, is that burn pit? Is that, is that COVID? You never got a positive test for COVID. So maybe you had it and it just never, the sensitivity of the test wasn't there. Like the diagnostics get kind of messy. And possibly some of the treatments will be harder to like pinpoint. What is it that will help you breathe better or feel less tired or concentrate better, have fewer headaches. We need a multidisciplinary approach to the symptoms that are going to be ongoing and plague the population long term here. You know, with a virus like chickenpox, you have it when you're 10, and then 50 years later you have an impact with shingles. We don't know long term what the impact of COVID will be. 50 years from now, what's that going to look like for folks who had it when they had no symptoms, nobody ever knew about it, but 50 years from now, what does it show up as? Yeah, we need to pay attention and think about that.
Can I touch back up on that?
Yeah,
Amy?
go ahead, Rosie.
Absolutely. I mean, you bring up such a huge point that this is such a vulnerable population. You know, according to the VA registry, 30% of participants reported a diagnosis of respiratory disease, and we know that that you know the biggest complication with COVID is respiratory failure. So you know, I'll just use my husband as an example. He was told that his respiratory distress was somatoform disease. And so it wasn't until we went and spent our life savings to go get the correct diagnosis of pulmonary fibrosis and obliterative bronchiolitis from our doctor over at Vanderbilt University. It wasn't until then that we really knew what we were dealing with. And so this it's scary, right? Because we, like you said, there's no treatment model or assessment model to really know, like, what is it that or is it not? And then the susceptibility, right? And the risk you put yourself if you don't know. So for us, you know, it was a huge challenge in trying to get those answers. But now that we do have the answers, you know, one of the lucky ones, to know that there is that compromised lung disease, that we really truly do not want to be out in public, because if, like his doctor said, if he contracts COVID, you know, he'll die because the lungs are compromised already. So yeah, just a great point on the vulnerable population we're dealing with, and thank you.
No, thanks. And Rosie, thanks for sharing that about Leroy. So really appreciate that. We have about 15 minutes left. So what I'd like to do is kind of go around the horn again and just kind of give everyone a chance if you have you know, any concluding remarks, and maybe address where you see some potential opportunities or strategies going forward to help deal with, whether it's dealing with some of the underlying conditions that veterans and their families face, whether it's dealing with maybe the mental health challenges, or maybe just dealing with COVID-19 itself. So if you got any thoughts on mitigation strategies or any opportunities. So Rajeev, if you don't mind, I'll start with you and we'll work our way around from there. Yeah.
I've tried to think of, you know, as we've been talking about mitigation strategies, I think the idea of identifying high-risk group, whether they're caregivers for adults, there's a recent CDC report that identified caregivers to adults might be at high risk for some of the mental health consequences of developing more mental health consequences, people who recently experienced a job loss. But, you know, I want to take the opportunity to kind of think of two things that we didn't touch on, but Rosie's comment just made me think about it. I think that as we're going in the long haul, we have to be thinking about this loneliness thing that we kind of keep talking about, but I don't know if we've really come, and I don't know if there is this great solution out there. And I really worry actually about some of our older veterans, as well as our older Americans, some of whom are in nursing facilities, who are dealing with, you know, severe bouts of loneliness, but who are also perhaps the most at risk of dying should they be infected. So how can we solve this dilemma, this quandary? I would love for us to like really engage in a national dialogue about reducing loneliness during a time of kind of quarantine and social isolation. The other thing that we haven't really touched on, but I think is the other epidemic that's happening alongside COVID is what, and you brought it up at the beginning, is the structural racism and kind of the race disparities we see in COVID. You know, there might be some I think that there's systems that have produced those disparities. And what we've been thinking about is, to what extent are Black and African Americans, to what extent are they disproportionately affected from a mental health perspective? We've seen, so we're thinking about it from a mental health perspective. How can we, how can the community and society kind of engage them in mental health services? How can we recruit more, Black and African Americans are underrepresented in mental health services. So how can we recruit them? How can we address stigma? And how can we really kind of serve that community that's been, at least from an infectious standpoint, what we know for sure is from an infectious standpoint, they've been disproportionately affected. We can presume that they may have had those mental health sequelae as well. So how can we better serve and mitigate kind of any adverse consequences from a mental health perspective for that population? And I think that will both require service delivery, but also requiring us to really look deep within our biases, our service delivery system, and think about the structures that have produced these inequities and how we can start dismantling those structures.
Rajeev, and thanks for bringing us back to that point, because I think that is an important point, that as we continue to have these discussions, we don't want to allow that to fade into the background, not at all. So, so thank you for bringing that up. Rosie, I'll go over to you next. And there's, I know that you've been involved in some significant legislation. If you want to touch upon any of that too, as well, as we go, legislation that could be helpful as we go forward, helping our veterans who've been exposed to burn pits.
Sure. There's so many consequences resulting from this issue, and I know Rajeev talked on pointed out the emotional, the seclusion, the isolation. That is just one part of this big picture of us trying to access help, right? And really turning to these nonprofits that are really bridging the gap. And so I'm grateful for all of you that really have helped our community. So, with highlighting some of those consequences being like economic, job loss, denial of compensation, stressors such as isolation, that lack of camaraderie right now that we're all going through as caregivers and veterans, and then the lack of health care really points to the solution for us being making sure that as we introduce legislation here with the 9/11 advocates, with Jon Stewart, and with this coalition of people on September 15th in DC that will provide a presumption of service connection for certain diseases associated with exposure to toxins. This is going to date back to Gulf War, so that's the beauty of the bill, that we're not excluding that population. Really just hoping that, through this effort, we will be able to finally, it's going to take a while and a lot of work, but hopefully we'll be able to address some of those challenges that we've been facing for more than a decade.
No, thanks, Rosie. And now I'd like to go to Cristy for your concluding thoughts.
One thing I'd really like to shine a light on is the children. So veterans have children and they need care too. I mean, that's probably as simple as it can get. And with so many pressures and responsibilities for the adults in the home, or the adult in the home, it's really hard for the kids to get care. So I think that we're going to have to think about how to do this differently, to provide even just basic services, or to have that be accessible for families where there's one parent in the home, or there's financial insecurity or food insecurity. So that we are not setting up a whole generation of children to become adults who don't have maybe the education, the stability, or the hope, or connection, even in terms of the loneliness that we were talking about, that other people understand what they've been through, and so that we can set them up in a different way. So I just want to say we got to figure out how to get to the kids.
No, that's a great
community.
point. And I had, this is timely too, because I was just having a discussion yesterday, with a mental health provider, and they, we were discussing the idea, when we talk about veterans, we just kind of focus on the veteran. And when we talk about mental health, it's just on the veteran. And we fail to take into account the challenges and also the stigma, just like with, there's a stigma associated with family members seeking mental health care. And so we're all about tackling, making sure we reduce the stigma for veterans, but we should also be talking about their families as well. You can't separate the two. And so no, thanks for bringing that up, because I do think that's an important point going forward. So when we talk about some of the barriers to access, and some of that is the stigma, we also got to think in terms of reducing that stigma for family members, just like we do with veterans, just like we do with active duty service members. So no, that was a great point. So, and Amy, over to you.
Okay, so I'm thinking just about some of the things that we can do for the veterans and the veteran community and the family members is that we want to instill hope, but we don't want to instill a false hope. There's a lot of big challenges right now, and we have to be trustworthy and we have to earn trust. So giving false hope or trying to pretend like these issues aren't in place, that's not helpful. A lot of veterans and their family members benefit from work that focuses on purpose and mission-driven work. I think that folks are really looking for a way to feel as if they're being taken care of and not excluded from care, but really being taken care of. And we have to be responsive to when folks do say, hey, I think this is an issue for me, and I'd like some help with this. Listen and really dive in and ask good questions and be a part of that. And then in terms of like working with stigma, no wrong door, let's just get in. Which way is it? Is it gonna be with the horses? Because equine assisted therapy and EGALA work, that's incredible stuff that helps people regulate their emotions and bring anxieties down and feel like you're in control of something and you have a reason to get out the door. Is it art? Is it gardening? Is it increasing your healthy leisure lifestyle? I'm really excited at our program that we've gotten to employ some recreational therapists, and that's meaningful work to do a leisure inventory and find out what are the things that you like to do. How are you not able to access those things? How could we maybe modify them in a way so that we can do them under the current circumstances? And so those are some of the things that I'm thinking of. We really do need to be responsive to things that people are willing to start with. And then from there, like, okay, now let's go in and let's seek that and let's work on that.
No, and Amy, your point about work with purpose, again, that's something that we can't emphasize enough. Probably beyond the scope of the summit today, but one of the areas where we focus on at Dixon Center is focusing on workforce development, and Rajeev touched upon this at the beginning where he was talking about making sure that employers understand the skills that veterans have or transitioning service members have when they enter the workforce. Part of it too is just making sure that our active duty service members, our transitioning service members, veterans, and our military spouses understand the opportunities to non-degree credentials and how that can really put you on a pathway to work with purpose. So we do a lot of work with organizations that provide certifications, certificates, licenses. Again, all those things that are going to make you more competitive in the workforce. Find you that work where you're going to get a middle class or upper middle class wage and really kind of set the stage for other things to be successful. So I think that's an important point. I just wanted to bring that up. Well, Sean, I don't know if we have time, maybe if some questions that have come in. I've looked at some here on the chat, but I didn't know if there's any questions we want tackle here in the last couple of minutes before we turn it over to the next panel?
There's been a lot of great dialogue in the chat, and as I mentioned to them, I think we're going to share that. It's sort of some follow-up questions from such it's been touched upon. We'll share that with everybody here, and so maybe as a follow-up to this event, we can get some more expanded answers and dialogue going. To sum it up in just the short amount of time we have left, I see a lot of questions about different data and data availability and data sets. And I think we all know, if we all had our fingertips on the perfect data and could answer a lot of questions, we could get to real world answers much faster, but that's not always possible. What in your mind are some of the biggest barriers and challenges on getting the data you need? Is it availability? Is it cleanliness of that data? Is it even knowing that it's out there, or is it simply having the resources to analyze it? What are some of the things that are blockers for you in getting the data you need?
I'd love to get out there if I could on that one, because I've been talking about this for I don't know how many years, but so this whole science to practice link, I would love it to be like able to say to somebody like Rajeev, like, hey, we have all of these people, help us design what we need to do so that you can have real-time data and we can feed that way, and then you can feed us back with what should we be paying attention to. I think the collaboration rather between people who are great at science and people who are on the ground providing the work, there's got to be a better way to do this other than like, I don't know, or funding mechanisms that support that kind of collaboration, even informally. So yes, it would be so, like, I didn't know about his paper, but it'd be great to know, like, where do I go get that? Or yes, I knew about RAND, that's the thing. I know RAND puts a lot of things out about veterans, but how do we get it?
I can say I'm happy to send the paper, but I think that in terms of the data, there is so much data being collected. I think the problem is the funneling of data and the interoperability. So, for example, mortality data. There are some states, and sometimes it takes a long time to determine if a death is a suicide. So, if we just that's where my passion is looking at suicide prevention. But then it needs to go from a local jurisdiction to the state to the federal to the CDC before we get a national picture of the estimates of suicide. And we have some death investigation jurisdictions in the United States that are using fax machines still, right, to transfer information. So it's kind of that interoperability, and then it's also finding partners like Cristy. So it's finding partners kind of across the United States to identify, to create those data sharing agreements and things of that nature. So I don't necessarily think it's the cleaning or the analysis capability. It's the on the ground, and interoperability, I think, are the biggest challenges. And that's why I think that there's a great opportunity for not just government to step in, but also private sector. And we can identify, how can we use our private sector partnerships and our public-private partnerships to really address this kind of data challenge that we're facing, this data surveillance problem. And lastly, there's just all these people who don't enter into healthcare systems. So how can we, do surveys that are representative of the population to make sure that we're picking up in, changes in drinking or changes in anxiety or depression among people who have not yet sought treatment. So these are the challenges.
No, those are great points. Well, I see our moderator for the next panel is starting to sign in, Sean. So I was going to, first of all, thank our panel members. You guys just fantastic. Really appreciated the conversation and the discussion. And so really appreciate you for lending us, about 90 minutes here this morning to kind of share your thoughts, and look forward to continuing the conversation as well. And to Cristy and Amy, our thoughts will be with you guys here, as dealing with the hurricane and how that works itself out here over the next several hours. But So, but I appreciate everyone, Rajeev, Cristy, Amy, Rosie, really appreciate your support to a very important topic this morning.